bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, and the Children's Hospital Foundation of Saskatchewan. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAFC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAFCTweets and using the hashtag CAFCPresents. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive.
Hello, everyone, and welcome to today's episode of CAFC Presents. I'm Doug Maynard, the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And before we start, I just want to mention the 2016 CAFC Annual Conference being held in Halifax, Nova Scotia this year from October 23rd to the 25th is just over 2 weeks away. There, of course, is still time to register, so hopefully if we'll see a few last-minute registrations come in from our CAFC Presents audience, and we'll see lots of the people that we speak to virtually every week. Maybe we'll see a few of you in person there. And if you want more information about the conference, you can go to CAFC.org for more information, to see the program, or to register or for any other information about the conference. All right, so today's webinar is titled Stepping Up the Hype, Integrating Mental Health Care Services. And HYPE stands for Healthy Young People Everywhere, and it's an international knowledge translation platform as a mechanism to integrate national efforts and to link with partners internationally. And today we've got some familiar voices that haven't been on the CAFC Present stage for a while, but may be familiar to many, as well as some new faces to talk about some of the programs across the country that are addressing mental health care services for children. So without any further ado, it's my pleasure to introduce the podium. First off, familiar to many out there in the audience, we'll have Dr. Ian Manion, who is a clinical psychologist and scientist-practitioner who has worked with children, youth, and families for over 30 years. He's an adjunct professor in the School of Psychology at the University of Ottawa, and currently he's the Director of Youth Mental Health Research at the Institute for Mental Health Research. And for the past 12 years, he served as the founding Executive Director of the Ontario Centre of Excellence for Child and Youth Mental Health. And then following Dr. Manion, we'll be hearing from a team from out west in British Columbia, Dr. Steve Mathias and Daniel Presnell. Dr. Mathias is a child and adolescent psychiatrist with a fellowship in addiction psychiatry and is the division head for youth mental health at Providence Healthcare in Vancouver. He's the executive director of the British Columbia Integrated Youth Services Initiative, which is an initiative to create 6 integrated youth health and social service centers and develop a provincial integrated e-health strategy. And joining him, Daniel Presnell, is the Director of Health and Academic Communications at Signals. And you have to read his bio on the Knowledge Exchange Network. It's just fantastically written. He's a communicator with 15 years of experience, and Daniel comes to Signals from his most recent position as communications manager at the University of British Columbia Faculty of Medicine, and there he used creativity and critical thinking to deliver a broad set of both traditional and digital communications that raise the profile of the Faculty of Medicine in the communities that they serve. But I do encourage you to read it because it's just fantastically written. And so without any further ado, it's my pleasure to hand the virtual podium over to, first over to Dr. Ian Manion here in Ottawa. Over to you, Ian.
Thank you very much, Doug, and we'd like to thank CAFC for making this webinar possible. CAFC is one of the partners of HYPE, and we're very pleased for that relationship, and it's a very exciting time for those of us that work in youth mental health in particular. Thought perhaps we could start with a little bit of a poll to get a sense of who is on the line, and if folks could use the online poll to let us know yes or no, if you are directly involved in youth mental health care. Please let us know.
So yeah, this is your chance to just provide some input just by clicking on the screen. Just an easy choice, yes or no. Just go up and click on the screen to make your selection, and we'll see who in the audience is directly involved in youth mental health care. And we'll just give everyone a few more seconds to put in an answer. We can see that 62% say they are directly involved in youth mental health care, and 38% are not.
Okay, that's terrific. And the second question before we move forward. How many folks currently on the line right now are already part of the HYPE network, Helping Young People Everywhere network? Yes or no, if you're already part of the HYPE network?
All right, so we do have some people out there who are familiar with the HYPE network. 11% said yes, and 89% said no, they're not already part of the HYPE network.
So that provides us with an opportunity. We're actually sharing information with folks who do not yet know what we're trying to do. We'll be talking about that today. And hopefully, if we do that poll down the road, it'll be much closer to 100%. So I think it's pretty obvious for anyone that works in child and youth mental health the scope of the issue. We know that when you talk to you adults with mental illness, 75% of them tell us that they first experienced symptoms of their mental illness before the age of 18, 50% before the age of 14. So this is actually a lifelong illness. Problems that occur first in childhood and adolescence, so we should be trying to identify, intervene early to change the trajectories, life trajectories of those that experience mental health concerns. Sadly, it's the minority that actually receive services. So there are clear issues with regards to access. Even looking at that limited use of resources, over the last several years, we've seen massive increases in people trying to access mental health services. Some Ottawa data, for example, we've seen a 69% increase in visits to ER with mental health concerns, similar kinds of things, even higher in British Columbia. We know that now if we don't address these issues well, the consequences are quite significant, suicide being the second leading cause of mortality among Canadian youth. It is much more significant than any health-related issue. All the cancers combined don't account for the same number of deaths as suicide would be. And in some respects, you can look at suicide as one of our indicators of system failure. Massive investments in terms of the cost associated with mental health, but the actual investment in terms of dollar in mental health care is quite low relative to the burden that it represents. Lots of service gaps, especially for transitional aged youth. If you happen to be 16, 17, 18, 19, up to 24, you may well fall between the cracks between the child system and the adult system, often disengaging from care when you need it most. So clearly we need different kinds of approaches to really help young people kind of care, the right level of care at the right time. Some of the problems that we know, a lot of young people will not discuss their mental health issues because of stigma. They won't even necessarily know they have a problem. Mental health literacy is an issue not just for young people, but their family members, and many professionals that are working in health and mental health care don't necessarily know all the things that they need to know. When you ask young people if they know they have a problem, they often don't know where to go for help, and they are not necessarily likely to go to the traditional places. So there are limitations in our pathways to care. They aren't always youth-friendly. They are often built for service providers, not built for those who want to receive services, and too often they're siloed. We have people that deal with youth addictions. We have people that deal with physical health and well-being. We have those that work with mental health, others that work with issues relating to employability and vocational issues. And a young person faces the challenge of trying to identify all those potential sources of support and accessing them in a very convoluted way. When we don't have clear pathways to care, and when things get very severe, unfortunately, young people will end up in emergency rooms trying to access the most specialized care, often creating bottlenecks and longer waiting times. And throughout this entire process, we have been remiss in how we have engaged young people and how to better create the systems to meet their needs. So if we look at the approaches that are happening now, there's a large movement in Canada to really try to integrate youth mental health services. And there are lots of initiatives. The Graham Beck Foundation, together with CIHR, funded a major research research grant in transformational research in adolescent mental health. I'll talk to you a little bit more about that. but increasing, we're realizing that it's not just government. For us to really be able to tackle this, everyone has to be involved. Funding has to come from multiple sources, including philanthropy, government, research, but also mobilizing existing community resources that may be quite fragmented in terms of trying to meet the needs of young people in those communities. There are significant efforts going on right now in several provinces. We're going to be highlighting a few of those. We're also going to be talking about some very innovative work going on in the province of British Columbia, and Steve Matthias and his team will be speaking to that. In some respects, they're ahead of the curve and have really, I think, building on the shoulders of others that have already done some significant work in this area. But we also realize that for this to work, it can't be a series of hidden gems around the country. They have to be integrated. There has to be a way to share knowledge and information, standardize our approaches, brand it in such a way that it's easy for young people to understand what's there for them. And that's why we'll be talking about the HYPE network. So the first piece of work that I think is really important to highlight is Access Open Minds Canada. They, led by Ashok Malla and his team, have been the recipients of major funding from CIHR and the Graham Beck Foundation. They really have been looking at a pan-Canadian approach, 12 sites with geographic diversity, cultural diversity, to have better youth mental health care for those aged 11 to 25 years of age. They have active involvement of young people and families, clinicians, service providers, very heavy emphasis on Indigenous groups and communities. And their role is trying to look at the whole process. How do you have early identification at the earliest possible time so you can have rapid access to the right level of care with the appropriate level of care at the right time? Looking at not just how you get into a system, but the continuity of care as you try to look at your more holistic needs. This includes making sure that those that are involved in providing care have the appropriate training in terms of what they need to know around youth mental health care and service delivery. They right now have developed very strong evaluation models that are being replicated by others. And it's that kind of information sharing that we believe will be critical for us to develop something in Canada that can mirror some of the good work in other countries like Australia and Ireland, where they have quite effectively branded integrated youth mental health hubs that really try to meet the needs of young people much more significantly. There are special projects including an entire province-wide initiative in the province of New Brunswick, but also looking at special populations like homeless youth, particularly in the Montreal area, and they have also done some on-campus wellness hub work in the province of Alberta. So Access Open Minds very much a leader in what's going on, a core partner of the HYPE network, and their view is really national in this respect. And we are very lucky to have the leadership of Ashok and his team. Looking at a more local piece of work, Youth Can Impact is a randomized controlled trial that's being led by teams in Toronto. They are looking very much on the ground and having 3 Toronto-based walk-in clinics, strong collaboration between specialized service providers and community-based mental health and social service providers. 4 hospitals that involve psychiatric services are involved as well. They have created these walk-in clinics, these access centers, co-created with young people and families and community members as well as researchers. The goal is to reduce a lot of those barriers I talked about earlier, to improve timely access to service, facilitate case navigation, really a step care model as we're trying to push more and more the right level of care by the right provider at the right time. So we use all of our resources more effectively, but also to access and pathways to more specialized services when appropriate. Now, this is a research study. The research component is looking at 14 to 18-year-olds, although the service component is broader than that. You can see that a lot of the same kinds of outcomes are listed at the bottom here because it's not just access to care, it's access to what kind of care, its impact in terms of reducing symptoms, but also improving functionings, doing it in a timely manner, but it's also the experience of care. How are young people and their families actually experiencing a different way of receiving help that they feel useful to them? The third example is the work that's being done in BC. I'm not going to go into detail because Steve will be picking up on that in just a minute. But we do realize that with all this work going on, how do we actually collaborate and coordinate our efforts within and across provinces, but also linking it to the good work that's happening internationally? How do we discover what models are working, share these models, scale them up where appropriate, make sure that we have all the right kinds of partnerships that are necessary, that perhaps develop standards of care where we know what to expect, we know how to measure things, perhaps using consistent tools so we can compare and contrast efforts from others. We want our approaches to be evidence-based. We want them to be youth-centric. We want them to be equitable in terms of diversity and geography. We want to measure outcomes that make sense to young people. And we don't want to reinvent the wheel. So how do we make better use of what we already know, not just in one community, not just in one province, not just in one country, but right around the world? So the National Center of Excellence International Knowledge Transfer Platform is a competition that we are currently in the middle of. We have a strong team right across Canada that's been developed. Our values are listed here. Obviously, we are focusing on integrated youth steps mental health care, which includes the integration of primary care, substance abuse, education. It's a strengths-based approach, looking at the promotion of self-management, heavy emphasis on meaningful youth and family engagement at all levels, even in the development of our network. Inclusive of Indigenous perspectives, we understand the particular challenges, especially in Canada, around First Nations, Inuit, and Métis populations, but we also recognize that there are similar challenges in other nations that we are partnering with. We realize the importance of technology, and it's going to be part of the solution because young people are telling us that technology should be a cornerstone of any care network. And if we're going to be doing this, we better make sure that we're evaluating everything to make sure that it works. So our proposed center, our HYPE network, has a number of overarching themes with co-leadership in each theme from Canadian and international partners. So in the first theme is what is the evidence base? What do we already know? And are we using it effectively? And what are our knowledge gaps? And how can we inform those that are actively involved in research to make sure that they're strategic in how they use some of the research resources to fill these knowledge gaps? Second theme is the whole issue of data and data integration, developing common tools, common metrics, common indicators for effective step mental health care across all the constituencies. And when we talk about data, there's clinical data, there's research data, there's health utilization data, there's economic data, and it's data across systems. We should be looking at outcomes not just in mental health. We should be looking at outcomes in health, in education, in employment, in quality of life. A third theme is one of delivery systems. We are looking at innovations of trying to increase access. To do that, we have to look at where young people are and where they want to access information and care. That means strong partnerships with schools and post-secondary institutions, place-based services and communities involving primary care, integrated health centers, community models, but also virtual delivery systems, virtual wellness centers, maximizing the use of technology. The additional overarching themes, one is around implementation science. Evidence is not enough. Knowledge about what others have done is not enough. How do we make sure that we use knowledge in such a way that it can stick? So how do we help those that are not the same stage of readiness? They may not have the same capacity. So looking at developing jurisdictions where there might be countries that are at a slower stage of development, or communities that have less capacity or more challenges. What kind of education and capacity building can we promote? What's the policy process, knowing that effective policy change can actually be a driver for system change and practice change? What are those community preconditions? How do we support rural, remote, urban areas that may have different challenges, but also some of the same challenges? And again, what's our overarching evaluation framework so we know that what's working works not just in one place, but it can work across jurisdictions? And our final theme, and this is a cross-cutting theme, obviously, youth and family engagement. In everything that we do, we believe that youth and families should be involved in policy development, in developing the research agenda, in undertaking the research, in informing practice, but also governance about whether we're getting it right or not. Some of our cross-cutting processes, if we're going to do this well, communication will be key. Like having the right partners at the table from all the stakeholder groups is important, and knowing that there are certain individuals that are better placed to have conversations or sub-conversations about issues of particular interest to them, whether it's data or technology or engaging challenging populations or disadvantaged populations, quality improvement, and all those implementation science supports I mentioned before. Some of the activities we see ourselves doing is mapping globally, so we know what we're doing, co-creation of tools and policy, and even a resource hub, so we put all the information in one place. Right now, we are a finalist in this process. There were 59 teams that were vying to be these centers. We're one of 8 finalists. 3 will be chosen. We have significant leveraging, huge involvement of philanthropy, and we have over 100 partners, 20 universities globally that have been involved. If we do this right, we'll be integrating our knowledge mobilization efforts. We'll be making much better use of what we already know. We'll have some common language of understanding of how to integrate our mental health care, particularly with youth in transition. And we can also inform the global research agenda, leverage additional resources in Canada and globally, and make sure that what we're doing is actually evidence-informed. And actually, we can even push our philanthropic partners because they also want evidence to guide their actions. So I'm going to stop there, but just ask folks 2 more questions before I pass it on to others. And based on the very quick overview that we provided about the problems, but also the goals and objectives of the HYPE network, how important do you feel the HYPE network would be to support the advancement of youth mental health care? I think you should be able to see that on your screen. Pass that over to Doug and his team for that survey.
Yeah, so the question is up on the screen, and once again, your opportunity to make your selection on the screen. Just go up there and click to make your selection of not at all important, somewhat important, important, or very important. We'll give everyone just a few more seconds to put in an answer. And we can see 48% said very important, 42% said important, and 9% said somewhat important, and nobody said not at all important.
That's encouraging. And my last question would be, how important do you feel the HYPE network would be to profile Canada as a leader in youth mental health care? So this is a goal of the NCE networks, is to really have Canada show up as a leader. And do you feel that that's something that's a realizable goal? How important do you feel it would be for HYPE to profile Canada in this way?
All right, so once again, make your selection on the screen. How important do you feel the HYPE network would be to profile Canada as a leader in this area? All right, we'll close that off, and we can see that 24% said very important for Canada to be profiled as a leader, 50% said important, and 26% said somewhat important. Again, no one said not important at all.
Great, thank you very much. So with that, I'm going to pass it along to my colleagues in BC.
All right, thank you, Ian. Great presentation. We did have one question that came through. I just wanted to make sure it got answered just while we're handing over to our colleagues out west. Christine asked, when did the HYPE network get started?
So it's interesting, when the effort for the Pan-Canadian Transformation Research in Adolescent Mental Health was happening with a competition across Canada. That was happening in 2014. And there were many, many teams across the country that were involved in that. Shortly after that, we decided that we were actually stronger together. So all the main competitors in that initial competition got together to try to build something that would truly be pan-Canadian and sustainable. So the conversations have been going on since 2014. We're now in 2016. We believe that we have a common vision and approach to how we can do this, both in Canada and globally. We have had great interest from our global partners, and it's really taken off, I think, in the last probably 6 months to such an extent that the conversations are significant, and funders are lining up now because they believe it's something worth investing in.
All right, well, that's great to hear. All right, so it looks like we've got our colleagues out west who woke up bright and early this morning to join us this morning. So I'm going to hand the virtual podium over to Dr. Steve Mathias and Daniel Presnell.
Good morning, everyone, and thanks for joining us. Certainly encouraged by your responses to Ian's poll questions. We were all thinking that if people had said not at all important, we were just going to give everyone an extra half hour to their day. So we're really excited to be here. Just going to talk very briefly about the BC Integrated Youth Services Initiative. We are one of the members of the proposed HYPE network, and one of our non-academic partners, our industry partners, is Signals. And so this morning we'll walk you through a discussion around what the BC Integrated Youth Services Initiative is. We feel really excited about this in British Columbia. And then we'll bring in Signals to talk about the branding work that they've done, explain what branding really means in the area of youth mental health, and talk about how it's going to be applied here. It really is a form of knowledge exchange and knowledge translation, and so we want to bring that as an exemplar. The BC Integrated Youth Services Initiative has been an initiative that's been underway now for 2 years. Our first proposal went to government 2 years ago this month. We received a promise of funding from government, Interchange Foundation, the Graham Beck Foundation, Michael Smith Foundation for Health Research, as well as the St. Paul's Hospital Foundation, to launch 5 sites in addition to the exemplar site that was already in existence that we'll talk about in a second. And so this is an initiative that is anticipated to have 6 sites opened in each corner of the province by May of next year. So the vision for this is really that the British Columbia Integrated Youth Service Initiative will transform how youth and young adults access health and social services within BC. As Ian talked about, access is such a critical issue for youth across the country. This is not unique to any given jurisdiction or province. In fact, it's not really unique to our country. But it does represent a big issue for us as service providers, knowing that our young people and families often do not know where to go for help, and that when they do try to access services, they tend to be siloed and truncated. So our vision really is to transform in a positive way how youth and young adults access these services in our country. So the question we asked ourselves 2 years ago is, what if we could create a space for all our community apps? And then when we mean by apps, we mean our community services. In other words, could we create spaces where all our services could reside so that youth experience one-stop shops? And what would be involved in doing that? We opened an exemplar site to start to understand this issue in March of 2015. And we did this in downtown Vancouver, where there was obviously a dearth of youth resources that were not really connected and not necessarily coordinated or working together, and where there was really a gap in low barrier access to mental health and substance use services. The Granville Youth Health Centre went through a very intentional process of being designed in partnership with Signals so that it was considered youth-friendly. Youth were involved in the design from the very beginning, and what resulted was a space that has been really compared to a .com or tech kind of company that's bright and doesn't feel at all like a clinic. Moreover, we have a wealth of services. This is a number of services that existed in the community that were brought together, and some that were newly created to provide the services you see at the Granville Youth Health Centre. Primary care, mental health, and substance use are key services or cornerstone services, as well as peer support. But we also have psychosocial rehabilitation, outreach to a lot of homeless youth, intensive case management, housing support, income assistance, and soon we'll have a developmental disabilities navigator. All these resources are often used by the youth that walk through the door, and it has streamlined the ability for young people to access the services they need, as typically a young person can come in and there's a staff member on site at some point during the week that can support them. More importantly, though, that our staff have developed an understanding of what it means to work in partnership. We've addressed confidentiality issues, and we also have focused on the client experience as youth come through the door. In order to scale this model up, we needed to create a backbone organization, and we did this over the span of a 6-month period starting in December of 2015. We added several staff, and our staff now are up to 15. We have a youth and family member or consultants from the Family Smart organization on the Backbone organization. We have a project manager and capital manager that supports the 5 sites to get their capital budgets and capital planning completed. We have knowledge exchange professionals. We have policy and partnership leads. We have a fund developer who works with our foundations and our philanthropic contributions, which are closing in on $8.5 million for this initiative. We have a communications lead that supports all sites to get the word out about the work that they're doing. And we have coordinators for research and evaluation. The 6 sites that were named in June, and as you see here, they really, for those of you who aren't familiar with the province, Vancouver obviously is the largest urban center, but Abbotsford it sits in the fastest growing health authority in the province, the Fraser Health Authority. Campbell River is a small rural community up island on Vancouver Island. The North Shore includes 5 Indigenous communities, as well as 2 of the most affluent communities in the country. Kelowna is in the heart of the interior of British Columbia, and Prince George is our most northern capital. These communities were selected after a lengthy expression of interest and convening phase that saw 25 communities apply, and eventually 5 selected in addition to the Vancouver site by an independent panel of youth and family members, as well as representatives from around the province and some representatives from the Mental Health Commission of Canada. Our principles are very straightforward. We aspire to provide a comprehensive system of care that goes beyond just mental health. We understand that services need to be timely and accessible. We need to have youth and family-centered services. We also feel that the integration of services needs to be intentional. In other words, it's not a haphazard process. Each community space has brought together a leadership table in advance of their application to show that the partnership is intentional. And we are now working with them to move forward with integration and the change management required for that process. We also obviously have aspired to provide evidence and trauma-informed care. The BC Integrated Youth Services Initiative now has over 70 partners involved in its 6 sites. These are the lead partners for the initiative. Each community has a lead agency, and these are agencies that have a long-standing history in the field of youth services. As part of our work, we've created a Research and Evaluation Methodology Committee, and this is something that's very exciting for us and aligns with the NCE thought process. We've brought together a committee of thought leaders in the area of research and evaluation of integrated services, and it includes members from the CAMH, as well as Access Open Minds and Headspace Australia, among others. And this group is leading us in developing our research and evaluation methodology. We have certain areas of focus for research. So there's a developmental evaluation. And one of our goals, to be quite frank, is having done this now, by the end of May, we'll have done this 6 times. We'll have opened 6 centers. We want to create a knowledge bank for folks from across the country to access in order to open up centers in various parts of our provinces. We recognize that this is a very challenging process for which standards do not exist. And so we are looking forward to understanding how to support others, and this is why we've had a developmental evaluator on board with the team. We've also have folks looking at other key measures, and we'll be using an innovative data collection tool to collect data as youth come through. As part of the network knowledge exchange process, we've created an operations network for the lead agencies. In fact, we met yesterday. This is a group of executive directors as well as clinical service managers that meet on a regular basis and to exchange experiences and to really accelerate the process that's required to establish these centers. So this is just a quick graphic to show you where we are. Really, the 6 sites are now in the quickening phase and will be joined by together by a brand DNA, which was revealed this week, and that Daniel will be able to speak to in a second. And starting in early next year, we'll have our sites working as a network here in British Columbia, with the anticipation of adding more sites in the near future. I'm just going to turn over the presentation to Daniel, if you'll bear with us for 30 seconds.
Steve, we did have a question that came in just when you were talking about the sort of concept of bringing this to small towns and all of the challenges associated with the rural environment. Nicole's just asking, what's the reality of this coming to small towns? She says she's from Yarmouth, Nova Scotia, and they would like to see this kind of thing in small towns in Nova Scotia, but recognize the challenges. Like, what's the reality of that?
Well, the reality for us is that there's a great deal of information that can be passed down from the larger urban centers to smaller communities, and certainly links made and in sort of a hub and spoke model, which is something that we're exploring actively with Campbell River, which is a town of about, its catchment is about 40,000, but it's a town that's far smaller than that. What we recognize is that most communities have significant youth resources working in their community, but have gaps. And so part of the process of bringing all these services together is that they effectively scanned and mapped the services that exist, identified the gaps that existed, and government was a willing participant in helping support with funding to fill those gaps. So in smaller communities, it is critical to be able to identify where the gaps are within this model, and then to identify how the network can actually support either with professional support or in the case out here with funding to support those gaps. But the model certainly looks different when it is a smaller community. These sites are standalone health centers, but we recognize that in smaller communities that a more place-based model is likely to work best. So a place-based model might include an office in a community center, some drop-in time at a primary care clinic. But really, it's the most important piece, obviously, is that there's an identified space that is welcoming to young people and that has an understanding of what youth and families need. If she would like to contact me more directly to talk about it further, I'm happy to have that conversation.
Thank you very much. It looks like Daniel's ready, so we'll continue on with the presentation with Daniel. Over to you.
Thanks, everyone. I'm going to talk a little bit about how we do this work, and I'm going to show you sort of the process and some of the learnings and findings for this particular project and speak a little bit about our work in general. Signals has been around for about 30 years, and for the last 20 years has had a real specialty and focus in health. Around 60% of our work is in health. And particularly, we've worked in mental health, and we worked, as Steve mentioned, on Inner-City Youth Program and the Granville Youth Health Center. So we had a lot of learnings already going into this project, but obviously, with the 5 centers and moving across the province, we were expanding scope, and we needed to learn from those communities and from the people across BC to see where we had things in common, where we had differences, and to try to understand our work together. So part of our objectives in working with us and working with Steve and his team, we were asked to basically facilitate an engagement process. So we knew that we needed to hear from youth, from families, from care providers, and from all sort of viewpoints and members of communities in these 5 locations. We also knew that we needed to create, our task was to create a brand, but the word brand usually makes people wince or recoil in fear and horror, or even there's a very small percentage that get excited when you mention this. But we needed to develop a language, a way to talk about ourselves, a story that we could tell about the work that would be meaningful to both the care providers and the funders and the people in the community who are going to be rallying around this. But most importantly, we needed to have a story and a language that would resonate with youth and families. So we needed to explore that. And finally, we needed to take all that work and that learning and try to figure out what would this look and feel like? How would we extend that story from our personal interactions to our spaces and to our online or digital properties? So that was the challenge. We began our work by looking at landscape research, and we do this for every project, and this was particularly important here. So when we did landscape research, we did it a bit differently. We looked for a lot of evidence-based publications in health that talked about branding in healthcare and that talked about sort of campaigns aimed at youth. And we were trying to create, again, an evidence-based sort of catalog of learnings and things around brands in healthcare and around campaigns and around the experience for youth, because we knew that we needed to have people feel like this was going to be trusted and the right move. We knew all intrinsically that this was right, but we needed the research to come along with us. So we pulled together a bit of a literature review around branding in healthcare. And when we talk about branding, we always say it's about the experience and the reputation that people inside your walls have and outside your walls. And so the evidence in the research world actually spoke specifically to this, so we were delighted. We also began to look at the landscape of youth mental health, and we looked at that in BC, across Canada, and internationally. And so when we were doing that, we were looking at different programs that are out in front, like Headspace, Pause, and Jigsaw. These are all examples of integrated youth mental health sort of projects. But we were also looking at the greater landscape of campaigns, tools and apps, centers. There's tons of work in youth-focused activities across Canada, so there's a lot out there. We also wanted to look at brands and things that were sort of in the landscape of youth. Our age range is 12 to 25, and that's a pretty impossible age range because your life is changing so much, and where you focus your energies and activities is quite different at 12 versus 20 or 21. So we wanted to look and learn from other brands that are communicating with youth. We know that youth in this age range are some of the most they're the most heavily marketed demographic, so they're getting bombarded with ads. We also wanted to look at the life and how do young people communicate? What is their life like? So we looked at subcultures of youth, and we looked at how they live and what kinds of activities they're involved in. We looked at their digital communication. We learned from statistics and surveys and a lot of work that they are visual communicators, that they prefer things like Instagram and Snapchat to have a visual element, things like emojis, all of this kind of stuff. So we looked at that. We know that a lot of youth-focused brands want people to customize the brand. Youth want to customize things. They want to make it their own. They want to give it a part of their own personality. And finally, a lot of the campaigns that are focused at youth are built around messages of empowerment. So we wanted to explore that. So we learned a lot from the landscape, and this helped us create a baseline, all of us, all of those people at the sites, as well as us here in the firm, in the studio, trying to figure this stuff out. We then went and met with communities. So we held a series of discovery sessions. These were 2 to 3 hours long. It's a facilitated session. I present some landscape research and then basically facilitate a discussion. So we did that in each site: Abbotsford, Kelowna, Prince George, the North Shore, Campbell River, and Prince George. We also had opportunities to engage youth along the way. So in Prince George, we had a separate youth session. And then here in Vancouver, we had a youth session with the Urban Native Youth Alliance. We also had youth and family members involved in every single site-based session. So in those sessions, care providers, community partners, family members, youth, pretty much always participated. This just gives you a snapshot of all the types of groups who came to the table. So lots of people from the school districts, people from the ministries, child and family development, lots of community players in health, whether they work at community clinics or in the social services sector. So a very diverse group of people at the table. We also had the great pleasure to go across Canada and to see what we could learn from other communities and other provinces. So we went to Winnipeg, Manitoba, and had a wonderful afternoon at the Norwest Co-op Community Health Center there with a large range of young kids on a summer afternoon, aged 11 to about 20. We had over 35 kids there. It was a pretty wild time. We then went to Toronto and had in sessions with some youth from Delisle Youth Services. We had some families with lived experience in a session, and then we also had the opportunity to meet at CAMH with a number of people, social workers, care providers, researchers. We then packed our bags and headed to ESCA, Nova Scotia, where we had a really just impactful time with the folks at the ESCA Mental Health and Social Work Service, as well as the youth there, really taking a deep dive into how they recovered from an epidemic of suicide in 2009 and what was really working for their community. It was a wonderful opportunity. So in that engagement, we heard things like strengths, weaknesses, opportunities, and threats. We heard reasons to believe. We heard things that we needed to address. We tried to explore the audience mindset. What were young people thinking? What were families thinking? What were care providers thinking? So this is just a highlight of some of the things we heard, that youth really are open to having this thing be collaborative and finding a way. We know that there's a lot of opportunities out there if we can figure out how to streamline and integrate these things so that the experience is consistent and easy to use. We know that there's a lot of people who we haven't heard from that we're going to have to reach, and we know that it's difficult to make sure everybody does this in a way that doesn't burn them out. We created personas so that look at how people think and feel and what they should be doing. We did this for youth, families, and service providers. And we use these personas to stay grounded in user-centered design. So this is what we're thinking about as we make decisions and as we build things. We also conducted market research, online survey with BC, the Prairies, Ontario, Quebec, and Atlantic Canada. So here we wanted to test, again, at a broader scale, our assumptions and validate what we thought we knew, as well as learn new things. There was a lot of interesting results from this, and I believe Steve and others will be sharing these in time. I'll show you just a little bit. Most people were in favor of integrated services. People found gaps in access. There's a lot of interesting findings. So this, we felt like, was similar to what we were hearing in discovery sessions and from people in person. Now, we take all that research and engagement and we try to funnel it into something that's useful. So here we talk a little bit about our brand promise and just a sort of introduction to what we're about. So we heard resoundingly that our brand promise is about connection and care. We're about connecting people to services and care. We're about connections internally, bringing all the services together, connecting with communities. Connection is a central idea here, as well as the care. That we're taking time to provide care, administer care, but we care about youth in general. We care about our communities. So for teens and young adults looking to improve their health and wellness, BC Integrated Youth Service Initiative offers connection, care, and resources for all of life's challenges. Designed with and for youth, BC Integrated Youth Service Initiative provides a single door to access someone to talk to, care providers for any health need, and friendly experts that can help navigate social services, resources, and programs. From a simple snack to sharing difficult discussions with someone you can trust, we provide teens, young adults, and their families safe, non-judgmental care, information and resources, social services, and other essentials for healthy living. Here are some of the characteristics that we heard consistently from the group: collaborative, trustworthy, respectful, dynamic, responsive, approachable. We then tried to create a list of, we didn't have to figure out names and what names would look like and how they would work. This is just an example of some of the name choices that we've explored. This is still being worked out at the moment, but here you can see a name that's sort of unique, as well as a rationale to how that name might work and what a tagline might look like, and as well how these names would work in signage and in places. So this is just an example of part of the process. Here we show a little bit about how the creative approach could look. So what kind of story can we tell through creative, and how might it look in a space, and what colors will be used? Again, in youth mental health, we are really conscious of the colors we use in trying to both find things that resonate and that are in the youth space, but also create the calm and the sort of experience that we want inside spaces. A couple of examples. Then finally, we wanted to make sure that all that we were learning could be applied to the space. So as we were going across the province, we were asking people what a space would be like, what would make them feel safe, what would make them feel welcomed, what would make it easy for them to use. We learned a lot from that process. And so yesterday, we facilitated what's called a design charrette. So we had care providers, family members, youth, people from communities. We had about 45 people there. We had them broken up into teams. We worked with an architect. And basically what we did is we took them through a really fun exercise of space planning and what things would be like. And so they got to use blocks, and there was 1,000 Post-it notes everywhere, and they had big sheets of paper. And so at each table, there were different groups of people from across the province, from different user segments, working together to try to figure out what kinds of activities will go on in this space. What should the furniture feel like? How should people find their way through it? What kinds of different rooms that we know are required, what should they look and feel like? And what kinds of interactions can we promote in the space? So it was a really exciting full day event. It was really meaningful, I think, just to see everybody collaborating and working on this. Lots of excitement now from this process, and a help to sort of inform how these centers are going to pull together all of these pieces. Finally, my last point here is this is a comment that came from a survey that when we asked what would people want, what would a youth want from the center, and they said we'd like snacks/condoms. And for me, we've joked a little bit about this, but I think it really resonates because it illustrates the great journey from 12 to 25, from snacks, being hungry, to growing, to kids who might not have enough food. Snacks is a way to get them in the door. But the condoms, to me, represent the real need to have information to support healthy decision making, and what happens when we fail to provide that information and we fail to engage people around the choices that they need to make to stay healthy. So this really resonated with me, and it's just a two-word way to sum up a huge amount of work. Thank you.
All right, thank you for a great presentation. And I, for one, am all on board with using branding and marketing techniques to promote this kind of information. I'm not one of the people who shies away from it, so great presentation. And while we've got you here, Daniel, we did have a comment come in. Maybe you can tackle this first question here, since we're on this vein of branding, etc. Julie is saying that one of the major critiques of the Headspace model in Australia is that there was too much emphasis on the Headspace brand and less on the actual services for youth. She's just asking, what can we learn from the Australian experience to make sure we don't face similar criticism in BC? And we'll start with you, Daniel, but then perhaps, Steve, you can jump in and comment as well.
Well, I think the key thing for us is that we are engagement-led here. So we've really made extra efforts to listen to people and to find out what they need and to make sure that any tools or things that we developed are responding to the needs we heard from the people on the ground. So I think first and foremost, by having such an exhaustive and comprehensive engagement strategy and executing that, we've really been conscious of what people need. And sometimes it means that things we thought, our assumptions, actually have turned out to be wrong. And so we've revised and making sure that we stay on target. I think that's key.
The thing that we would like to learn, this is Steve here, or what we've learned is that where we feel that Headspace may have been aired somewhat is by an over-focus on mental health in their brand and in their service delivery model. And what we've discovered through countless hours of sessions with young people is that if we want to destigmatize something, then we need to really normalize the service-seeking opportunities that they have, so that if they're coming in for income assistance support, if they're coming in for employment support, it's been normalized, or it's normative, that you might also get mental health counseling on site, or that you might also drop in and see someone about your substance use, so that it really becomes a true holistic experience and not one that is that quite frankly is experienced as multiple doors in multiple community sites. And so I think that's something that we will hopefully stay clear of in terms of an over-focus on branding by making sure that this type of service and the services that we provide resonate more with youth and their families.
If I could just add something, it's important to realize that Headspace really grew out of the early psychosis kind of work that was going on in Australia, and they extended the model, which is why you had that primarily illness focus. Those of us that are working in this area in Canada really look at the full continuum of care, the importance of wellness promotion and mental health promotion and early identification and a real holistic view of what this could look like. By meaningful engagement of young people and families from the very beginning, we're understanding not just how do we need to deliver services, but what they need to look like. And also, if we do it right, what should the outcome be? What's meaningful in terms of an outcome for young people and families? Outcomes for young people and families are not always the same as the outcomes that service providers may be looking at. And I think that they're going to keep us honest in the process to have the right kind of balance between branding and care and access and look and feel and the right kinds of outcomes.
And Julie, who asked the question, said, great response, and thanks to everyone. So we're going to go, we've got a few questions that came in just at the end of Ian's presentation, but we'll give this one to Steve first. It came in as you were talking about the BC program, Steve. Allison's just asking about if youth can walk in with no referral to any of the centers. Are youth in crisis managed on site? And what are the hours that it's open?
So great question. So our hours are more youth-friendly. So our hours, for instance, will be at least to 6 p.m. and in some cases into the evenings. And we've asked that sites do as much as possible to provide service on Saturdays. Yes, there's a walk-in component to what we provide. So we will have walk-in counseling available. And obviously, we'll understand what demand is very quickly when we have that model provided. We will be using solution-focused therapies to work to support young people when they come in crises. And obviously, if they require more, then each center will have links to their local hospitals if that's what's required. We've had the health authorities and acute care really strongly support what we're developing here, and in anticipation that we should be able to mitigate some of those crises and keep the young people in the community so that they don't have to go through further stigmatizing experiences by going into an emergency room.
All right. Thank you very much. So we're going to go back to one with during Ian's presentation. Christine says, awesome presentations. She's now psyched for hype. But she also had a question where she said, as you were going through I think, Ian, you were talking about the ERs as the crisis point for many of these children and youth. She said, are peers part of the target group for some of these activities? She says, while we may see the ER as the crisis point for some, the experience of youth reflects their peers as being the front line to their friends to mental health and substance abuse events.
So I totally agree with Christine. I think that one of the things that's come up often is what is the role of peer support in these access points. And peer support is actually exploding in Canada. We're learning more about it. Effective peer support has some core elements, including being linked to other support. So you don't do it in isolation. It has to have the right kind. There are now standards evolving around peer support. Peer support can be an alternative to more intrusive care. It can be a step-down process for those that have already received more specialized care. It could be a step-up, where you're involved in peer support while you might be waiting for more specialized services. I think it's a very effective tool. And if you look at peer support, it's something that can be done face-to-face, but also virtually. Reach gets increased tremendously. There are some good models in Canada where we looked at peer support. I've had the privilege of being involved with the Youth Net Réseau Ado program now for over 20 years, where young people have told us that being able to link in meaningful ways with other young people has been what has saved them and made them feel of something as part of something bigger than their problems. So absolutely we want to take advantage of peer support, but we want to do it in an evidence-informed way. And we want to do it in such a way that we are being protective and not endangering whether they are the peers that are being supported or those that are doing the supporting.
All right, thank you very much. And just to go back, we'll keep you on the line, Ian. You asked that question earlier about sort of Canada as leading, being seen as a leader in this area. Christine was asking, what are the unique mental health contributions that Canada can make to the world stage?
Well, go ahead, Steve. Oh, I thought that was Steve. So, I mean, when we talk to our international colleagues, I mean, they realize that we actually do some things extremely well. Our work in youth and family engagement actually places like Australia look to us in terms of how we've done that. We have integrated a lot of different kinds of sectors here, and I think that that's something that people are really excited about. Because of our geography, we've had to be creative in terms of our communication. So some of the ways that we've done that, I think, have impressed other people. There are some things that we need to do better, and we can learn from others. Our engagement of Indigenous people, I think we've done very well in certain jurisdictions, but not so well in others. The bilingual nature of our country has made us had to be sensitive to language and culture, and how do we make sure that our processes are acceptable to more than just one mainstream group. So I think there are lots of things that we can do. I think also the Canadian persona is such that people like Canadians, and people like the fact that Canadians can invent things and do so usually with selflessness. In talking with international colleagues, they often ask Canadians to step up and take a leadership role. So I think we have to be prepared to grab that role, run with it, and look at the global impact that it can have for everybody's well-being.
All right, and Steve, if you do have, or Daniel, if you have anything to add to any of these, please don't hesitate to jump in.
If I could just add one thing to that, I met Ian Manion 4 years ago, but up until then, it really felt like we were working in a silo here in British Columbia. And I think what's happened in Canada in the last 4 years has really excited not only those of us working in this field, but also folks that are observing us in other countries, because they're seeing sort of a very rapid coalition of like-minded professionals coming together and making some sea changes here in the country. And so I think that's the other thing that is maybe difficult to really communicate to those folks on this webinar, but that there has been, I think, a tipping point in the last couple of years in this area.
Much. We've got two more questions. We are a couple minutes over time, but I think we're going to, if our presenters are able to stay on with us, we'll try and get through these last two questions. And those who, a few people have had to leave, but hopefully they can come back to the recording and catch the responses to the questions. But first, Daniel, a couple people asked if they'll be able to get a copy of that PowerPoint presentation, if we'll be able to post that on the Knowledge Exchange Network along with the recording. You had some of those great infographics and everything that people want to take a closer look at. So are we able to share your presentation?
A lot of that material is still in draft and being worked out with Steve and the group, but I think we can figure out what we can share. Absolutely.
All right, and whatever you can get to us, we will post on the Knowledge Exchange Network, and people will get an email when the recording's available, and hopefully we'll be able to get some other resources up there as well, some of those that information.
We are working with the team with the intent of taking all of our learning and making sure that it's translatable and shareable once we sort of reach a place where everything is sort of approved and working. So. All
right. Thank you very much. Steve, Laurie's asking, is there any thought, when you were talking about the BC program, is there any thought of having centers attached to or co-located at schools?
Yes, absolutely. All of our centers have a relationship with their local school district. Most have an emerging model that will see clinicians either working in the school or with a nice streamlined referral process from the school to the centers. One exemplar is the North Shore that actually has counselors in their alternate school. And will then allow the youth during the summer months to readily access services at the center when the school is closed. So we don't see this as an isolated model at all. It really will be integrated with the local schools.
All right, and one last question for you, Steve, and then we'll just go through the panel just for any closing comments or key messages you want to leave the audience with. But one last question for you came in from Sandy, and she's just asking if you can speak, Steve, to the evaluation that has been done so far on youth reporting their experiences.
Yeah, so to this point, what we've been using is a 26-point satisfaction survey, and the satisfaction survey has guided us in terms of changing certain elements of the space and center. We've also used a youth advisory committee to really guide us in terms of changes to the physical space and also how our staff go about doing things. The satisfaction survey has certainly given us an impression that we're on the right track with the space, the design, the fact that we have multiple services in one place. But we want to take it obviously to the next level and really start to understand what the actual impact is on young people's lives, and really follow up with the kids who don't come back and understand. And I think that's one of the challenges with evaluating any program, is that you obviously have a bias in terms of who you're evaluating. So we need to grow that out and really understand who are the youth that don't come back. And I think that's probably a more important question than who are the youth that do come back.
Thank you. A great answer. So with that, I think this is our time to wrap up. We are losing some of our audience as we are gone a little bit over time. So maybe Daniel and Steve will go out to you guys first for anything you'd like to leave the audience with, any key messages.
I'd like to just say that Steve and his team allowing us to take a meaningful human-centered design process and it has been instrumental in this work. So what that means is actually going to the people who use the system and asking them what would make it better, and not just doing that in a tokenist way, but to actually take that information and use it to make decisions. That has been a wonderful experience, and the people who have been a part of it have told us so. So I just think that in all of this work, as we try to shape or build a patient-centered system of care in Canada, that it's really important that we keep in mind how we're going to engage people who really need the system to work for them.
I would add that as a service provider, as a psychiatrist, I had learned that I had made so many assumptions for years that proved to be false or needing to be realigned with what the branding process told us. That said, once we got the brand DNA, that key promise, it resonated with us as service providers and really gave us our true north, which I think is critical. I think we often give lip service to community engagement and youth engagement, and I think we also give lip service to branding, and recognizing that a name is just really the tip of the iceberg, and that there's a whole wealth of information that can be gleaned from proper branding processes, such as the one that we've just undergone.
All right, thank you very much. And then we'll go back out here to locally to Ottawa with Dr. Ian Manion. Anything we'll give you the last word if there's any key messages you'd like to leave everyone with.
Well, I think that the key message is timing is now. This is the right idea at the right time. Young people are telling us that it resonates. There are conversations happening with provincial governments right across the country. There's a level of enthusiasm about how a model like this can solve a lot of the access problems, whether it's looking at the age gaps with transitional aged youth or the integration of mental health and addictions, or looking at mental health from a holistic perspective, including promotion of wellness. If we don't do it now, if we don't see the opportunity and seize the opportunity, we will have missed our chance. And let's be honest, there are hidden gems. People are doing this kind of work right across the country. We just aren't linking them all together. And I think that's also an opportunity for us to have a much better communication of what we're doing well when it comes to youth mental health care. I also want to thank the folks at CAPC for making this webinar possible. Thank you, Doug, and all the help you've provided for making this, I think, a very successful webinar today.
All right, well, thank you, and also thank you to Ann Watkins, of course, who helps with all of our webinars. And inspiring words to leave us off with. I think it was a great way to end this, Ian. Fantastic key messages there. And if people are interested in more conversation across the CAPC community about integrated service delivery models for child and youth mental health, we do have a session at our annual conference in Halifax. So I believe it'll be on October 23rd, the Tuesday, and it's titled "Demolishing Silos and Lowering Barriers: New Models of Mental Health Services for Children and Youth," and it'll be very much along the same kinds of conversations that we've had today, so hopefully we'll see many of you out there at that session as well. All right, so thanks again to our great panel, fantastic presentations, and an excellent audience who, as always, when you get the chance to contribute your questions and comments, it really enriches the discussion. We do our webinars every Wednesday at 11 a.m. Eastern Time, but when you can't be with us live, you can always watch the recordings that we make available after the fact on the Knowledge Exchange Network. Next week, on September 28th, will be our last presentation just before we go on a brief hiatus for the CAFC conference. And next week will be, the title is Thinking Differently, Navigating Research, Business, and Innovation. And this session's coming to us from our colleagues at the Children's Hospital of Eastern Ontario Research Institute. And we'll be hearing from Dr. Matthew Bromwich, who will draw on his own personal experiences of researching, developing, and marketing several medical devices to highlight the various mistakes he has made and the successes he has encountered. And one of those successes being, if you recall, a few years ago when CAFC did the Dragon's Den session at our conference, he actually won the Dragon's Den session. But specifically, he wants to talk about private sector collaboration within the broader public healthcare sector. So it's going to be a really interesting, innovation-focused session there. And then right after the conference, then we'll be having our short hiatus for the conference, and then we'll be coming back, continuing our new series, separate from the CAFC Presents series, our Life with the Preterm Baby series, where we've partnered with the Canadian Premature Babies Foundation on a 6-part series aimed to provide information to parents of preterm infants, although it's also a great resource for healthcare providers as well. We had a great turnout for our first episode, which focused on the importance of movement for newborns and preterm babies, and our second episode will focus on common winter illnesses that parents of preterm infants should be prepared for. And we would like to, as always, thank Prolacta Bioscience for their support that has made that webinar series possible. So as always, a great presentation today. Some great stuff coming up in the next few weeks. Thanks to everyone for joining us today, and we hope to see you back here next week. Bye, everyone.